Okay, good afternoon, everyone, and thank you for joining our COVID vaccine webinar. This is a collaborative effort between the Bassett Healthcare Network and public health departments in our area, including Otsego County Public Health today. I'm Scott Cohen. I'm the medical director of the Shenango County Health Department, as well as the chief medical informatics officer for Bassett. This is a very timely event. We actually didn't plan it this way, but the rollout of COVID vaccine just happened right in the middle of this, and we're very excited to hear that Pfizer vaccine is up and rolling, has been given already, including in our snowy state, and that the rollout for Moderna vaccine will likely be soon as well. Today we're going to talk about the types of different vaccines that are out there. We're going to speak about the efficacy of the vaccines, which turns out is a lot higher than we had initially anticipated. Potential side effects. We really want to talk as well about the myths that are out there about some of the vaccines, and some of them really have some significant basis in fact, and others really don't. And then we're going to go through what are the delivery times? How are these vaccines being distributed? When will people likely get them? And granted, we don't have all the answers to that, but we are going to try to answer as best we can. So I'm going to turn it over first to Dr. Kelly Rudd. She is our Network Director of Pharmacy Services, and she's a PharmD working for Bassett. So Dr. Rudd, I'll turn it to you.
Thank you, Dr. Cohen. So a lot of excitement about this COVID-19 vaccine and the new advances in technology that come along with it, really allowing our medical community earlier access to this vaccine than we have in any others. So a lot of questions about that. So we thought we would talk through a little bit how this vaccine is made and is a bit different from traditional vaccines that we think of, such as the influenza vaccine. So other vaccines historically have taken a piece of the virus, either weakened or dead, either the whole vaccine or a piece of it, and introduced that into the body. With your immune system recognizing that as something is foreign and shouldn't be there and building an immune response. With this vaccine, the two that are out right now from Moderna and Pfizer work a little bit differently. So instead of having to grow the vaccine, or excuse me, grow the virus, either weaken it or kill it, mash it up and take a piece of it for inclusion into the vaccine, these Moderna and Pfizer COVID vaccines actually use our own body to create a piece of that spike protein on the external side of that COVID vaccine. So if we think of the pictures that we see on the media, there's that very characteristic spikes that stick out all around the vaccine. So all around the virus. So this vaccine takes a protein called mRNA or messenger RNA, which is not DNA, but it's a protein coding for the production of that spike. So the mRNA, the protein, is introduced into our arms through the vaccine, and it tells our local cells to produce that spike protein. It's not producing the COVID-19 vaccine, but it's producing the outside of it, something that our body will recognize if we encounter the COVID-19 vaccine in the future. So it's actually building an immune response to that spike protein without having to introduce any virus into our system. There are other vaccines in development from other companies that work a little bit differently. Those are a little bit further off, so we won't talk much about them. And as Dr. Cohen noted, the Pfizer vaccine has already been approved by the FDA, and we expect the Moderna vaccine, which was reviewed yesterday by the FDA Advisory Committee, to come out here very shortly. This is very exciting for our medical community, how quick industry was able to produce this vaccine. And I know that has some folks worried about, have we had enough time to build this? This new technology allows us to move much more quickly. And also, we were able to put a lot of resources to the development of this vaccine. Being a global pandemic, development in other areas were really halted, and a lot of teams were really just focused in on one project, development of this vaccine. Production of other vaccines were slowed. There was government support to ramp up production of this vaccine. And if you think of it much like an assembly line, so in producing a vaccine, of this caliber, there's a number of steps that have to happen in order. So if you think of it like building a car, the motor has to be built, it has to be put into the chassis, then the interior has to be put on in the wheels as it moves down the line in increments. That's typically been our vaccine development, one step at a time leading to the next. With all of the attention and all of the need for this vaccine to really halt this global pandemic, think of the development of this vaccine more of a NASCAR experience. So all of those steps happening in quick succession. So the driver pulls in, the tires get changed, there's fuel in, the driver gets a drink, all very efficiently, all with the top notch of safety, but with the idea of getting it done as efficiently and safely as possible. And that's really what's happening with this development of this vaccine, is that so many teams are working simultaneously to get these vaccines out into our hands much, much sooner. So a little bit different approach, not introducing the virus into our systems, having our own bodies create that spike protein, breaking down that messenger protein rather quickly so it's not in our system for very long, and really doing it in a very clean and efficient manner, which leads into highest amounts of efficacy for vaccines that we've seen in a very long time. And I'll pass this off to Dr. Hyman, a senior attending physician in infectious disease and infectious disease specialist here at Bassett. Perhaps, Dr. Hyman, you could tell us a bit more about the efficacy about these vaccines and what we're seeing with them.
Sure. Thanks, Kelly. That was a great introduction, and I'd like to thank everyone for joining us today. I'd just also like to give a slightly different context or provide a context for how we're going to be looking at information about these vaccines. I think we're all familiar with influenza, and on a yearly basis, influenza kills about 30 to 60,000 people. So far this season, it's not even a year yet, this virus has killed over 300,000 people. So we're talking about a viral infection, a disease that is 10 times as deadly as we usually encounter with influenza. So I think with that in mind, talking about the efficacy of these vaccines that are available is really important. I'd also like to give a brief overview or a comment about the immune system. I think I find it helpful to understand the immune system. I think of it sort of like the armed services. I like the NASCAR analogy, and I'm going to use armed services for the immune system, whereby the immune system is tasked with protecting the body from invaders. And there are different parts of the immune system, just like there are different parts of the armed services that each have a different role that overlap ultimately to protect the body or the community. And that's what the immune system does. And so what vaccines do is they prime the immune system. They tell the immune system, this is something you need to be on the lookout for, and that when you encounter it, this is how you need to act against it to control it. And so that's the purpose of viruses. I thought the comments that and the description that Kelly gave about how different these two new vaccines are was really excellent. And they present for us a new technology in vaccines that's, I think, really important and is proving to be very efficacious. So let's talk a little bit about how effective are these vaccines. And I would encourage folks, while there's a lot of in-depth information out there, you can actually go to the source information that the FDA themselves use to review these data and determine whether or not these vaccines are safe and effective. So for folks that are really interested in this information is available to you. You can get it on the web. It's right there. So how effective are these vaccines? Well, again, to give you a context, in a good year, the flu vaccine is about 50, 60% effective. That's in a good year. And that was the bar that was set for the efficacy of vaccines against COVID. Well, these two vaccines that are being produced by Pfizer and Moderna have been shown in their clinical studies, which have included between 30 and 40,000 people, to be 90 to 95% effective. That's just fantastic. Now, what do I mean by effective? So what that actually means is its ability to prevent the disease. We don't know whether it's the ability to prevent infection, and I'll come back to that in a minute, but the most important thing is it prevents disease. And if you get the disease, it prevents the complications from those diseases. So in other words, if you get the disease and you get symptoms, they're usually much milder, they resolve, and it's 80 to 95% effective in preventing you from getting serious disease and getting very sick from this. So I think that's really fantastic news. You can be sure that I'm going to be first in line if I can to get the vaccine myself. But it's very efficacious, and it's efficacious for all age groups, for people that do and don't have risk factors for getting severe disease from COVID, those of us who are a little bit overweight, those who may have diabetes, those over the age of 65, such as myself. So this works for all of us. And I think another major concern is safety. How safe is this? And I think people are very concerned about this because, as Kelly mentioned, the process, the NASCAR process to get this out there has been super fast. And I'd just like to add a couple of points to that. I think, generally two of the major hurdles that slow up the production of any medication or vaccine are regulatory hurdles. In other words, the government puts in place very definite constrictions as to how things should be developed, and they serve as an important watchdog, and also money. These are very expensive processes to develop these types of medications and vaccines, billions of dollars. And I think in both of these cases, both of those hurdles have been removed so that the means to allow companies to use the NASCAR approach, as Kelly put it, has been very effective, but without compromising the safety. So the safety of these vaccines, I'm going to address that in two ways. One is local reactions that people get, and the other is the systemic reactions, serious adverse effects. So certainly local reactions to the two injections are very common. We're talking about a half to 2/3 of people are going to experience some pain, some discomfort, some redness, some swelling at the site of the injections. And just to remind folks, these are vaccines that are going to require 2 doses, usually between 3 and 4 weeks apart, 2 doses. But for the serious reactions that people might get, and I'm talking about high-grade fevers, prolonged fatigue, other unusual manifestations have been extremely low, usually on the order of less than 1%. Now, it's difficult to know when you administer vaccines or a medicine to tens of thousands of people, you may not get a clear picture of all of the potential side effects. And frequently things may occur that may not be related to the vaccine. When you start giving this to tens of millions of people, a different picture may emerge and demonstrate that the safety is in fact essentially not that much different for serious side effects as it is for placebo when you get nothing at all. So I think we can be assured that in the studies, there haven't been any important or significant events that should concern us about the safety of these vaccines. And I'm sure as we roll this out for more and more people and millions of people, we'll also see that this is a safe vaccine, or these are safe vaccines. And one other point that I'd like to come back to that Kelly made is that the nature of these vaccines, and what's different is they're not injecting foreign parts of the virus or the virus themselves. It's actually a part of the mechanism that helps create a small part of the virus that then gets broken down. So after a period of time, there's no residual elements of the vaccine that are left. It's cleared by the body. So I think that's also that should make people feel comfortable that these are going to be very, very safe vaccines, as has indeed been shown by the studies that have been done to date, albeit in less than 100,000 people. So with that, I'm going to stop there and invite our next speaker to talk about other aspects of the vaccination program.
Thank you, Dr. Hyman. And you made some really good points too regarding some of the removal of some of the barriers to really get these approved quickly. And one of the myths we were going to discuss, but since you covered it really so well, is how did this get through so quickly? And you mentioned removal of regulatory barriers, money. I like Kelly's NASCAR analogy, which is great. One thing I don't think any of us mentioned yet, which is really important just in acknowledging, is that the number of volunteers that came forward in such a rapid fashion is really part of what pushed this through quickly. And we have to thank them because, we didn't know that this was going to be as safe as it appears to be right now, either of the two vaccines. Normally, when we do studies, it takes years to, get enough people enrolled to get proof that a drug is both safe and effective. And in this case, because so many people stepped up, and I've heard some, analogies out there where people said, listen, I'm stuck at home. I really feel like I want to give to the movement of being able to help my fellow Americans and other people around the world, that I'm going to do this. So that was very important as well. Did you have another comment, Dr. Hyman?
Well, I have many comments, but I think that the points that you're making are really good ones. Mm-hmm. And, I think we always need to thank those people who are stepping up and making themselves examples of what it means to volunteer.
Mm-hmm. Absolutely.
And you mentioned, the breakdown of some of the regulatory barriers, but, that I think through this process was some of the most involvement that we've had of our medical community leaders, both federally and, experts in the field, really working hand in hand through these protocols and through the trials with the volunteers and making sure that the science was absolutely top notch. So even though, folks, we broke down the regulatory barriers and working very efficiently, there was a lot of work from all the experts in the field and from regulatory to make this work very smoothly and very safely.
Right. And I would say that I think governments have, when I mentioned money before, for drug companies to make a product like this is a huge investment, mm-hmm. time, and there's risk involved in case, it doesn't work. So I think the government stepped up to say, well, we guarantee we're going to be buying, billions of doses of this. We will guarantee that. And so it made it much less of a financial risk for the pharmaceutical industry to really go full speed ahead on this.
Mm-hmm.
Absolutely. That was great. Yeah, I was amazed that Pfizer specifically didn't accept any money from the feds, but did obviously get a contract for their doses. But both companies and others knew there's a good chance that if they were not effective, they would have to throw out all these doses.
Right.
To start production as early as they did is why the second, we proved that it was safe and effective, we got an emergency use authorization and boom, it was rolled out and shipped. The process, I think we all are saying was quite well done, mm-hmm. and saved many, many months of lag time, versus the NASCAR analogy that Kelly gave earlier. So very interesting. I was reminded by Diana Parker, who is our facilitator here, that folks can please type questions in our Q&A section after we go through, our discussion portion here, which should, wrap up in about 10 or 12 minutes. We're going to take questions. We'll try to answer as many as we can in the time that we have allotted. So please type your questions into the Q&A section If you're on the phone, if you have access to any of our emails, you certainly can do that. But the Q&A section of the actual Zoom is the best way to go. So moving on, one other comment on side effects. I did see something from the FAA actually yesterday. So they are very conservative with new drugs, so much so that they don't allow pilots to fly many times with new drugs or vaccines. In this case, they were impressed enough to say that pilots are just grounded for 2 days after they get the vaccines. And that is it's a wildly conservative organization, as you might imagine. So that statement coming out from them was quite impressive. So we're going to move on to kind of our Mythbusters section. And there are a bunch of myths out there that really have some significant basis in fact, and others that probably do not. I'll try to kind of ask these questions of our panelists here and see what they think about it. So I'll start on, there's one out there about Bell's palsy. There were concerns that Bell's palsy, one-sided drooping of the face, may be more common with folks getting these vaccines versus not. I don't know, Dr. Hyman, do you want to comment on that?
Yeah, so there was a numerical difference in the number of people who developed a Bell's palsy and those that had vaccine versus those that didn't. But we're talking about a very small number. I don't remember the exact number. I think we're talking 4 versus 1. I mean, it's that order of magnitude, very, very small numbers. And that's what I was alluding to before. When we start seeing millions of people getting vaccinated, then these things start to be put into context, and frequently they go away, and we see that they're no more frequent than you would expect in the population in general. And I think, in fact, even though there was a numerical difference in the number of people who got Bell's palsy and received the vaccine, it was really no more common in that group than it would have been that you would expect in the general population. So this is not something that worries me. Also, there's no real mechanistic connection between why that should be. So I think this is probably just a little blip and will prove not to be an issue in the future.
Thank you, Charles. So Kelly, Dr. Rudd, you and I had spoken earlier. There was an initial concern that perhaps these vaccines can generate something we're calling anti-placental antibodies, meaning antibodies against maternal placenta, and that there were some rumors out there that these vaccines could cause mass sterilization. Can you comment on that?
Sure. So I initially saw it on Facebook, right where you see all of your really great medical information. We had a very nice conversation about that, and doing some fact checking on that. Really coming up with this is most likely a myth. So the vaccine was not studied in pregnant individuals. So that will have to be a conversation with a pregnant woman and her healthcare provider. So it appears the initial reports on this were put out by a former Pfizer employee. And really the basis for that was, we had talked about, the vaccine development really triggering an immune response against that spike protein on the outside. So the theory potentially was, and antibodies to fight that are also found on the placenta. But it's important to note that they're a completely different kind of spike protein. So I liken it to males and females are both humans. Placental spike proteins and COVID spike proteins are both spike proteins, but they are completely different. And different enough that this vaccine is so sophisticated that it will target only the COVID-19 spike protein. So it's not actually building antibodies to the placenta, or we're not theorizing or expecting any risk to pregnant patients from attacking the placenta. So that, factors into that decision, but really we're calling this one a myth. Scott, what else did you have on your list of myths that had come up?
I've got a bunch. I've got one for Heidi now. So Heidi, this is just a good one because both you and I do some work in public health, you more than me. But there's a myth out there, another, I think, Facebook myth, that the government is using these vaccines to chip the population, to use tracking chips so that, we know where people are, what they're doing, that sort of thing. Can you comment?
Yep. So the vaccine is not microchipped. It does not contain any anything that would put a microchip into your body. I like to tell people that that kind of bring that question up is all of us have these right here, the phones. And anybody who wants to track what we're doing, where we are, what we're looking at, what we're shopping for, what we're talking about is right here in our phones. So nope, the vaccine is perfectly safe in that sense.
Absolutely. Thank you for that. I'll take this next one. There was a myth that the COVID vaccine, specifically the mRNA vaccines, can cause narcolepsy. All the data, all the research I did on the data says that is not the case. There is no increased risk of narcolepsy from this. And as Dr. Hyman said, it just from a structural standpoint, it doesn't seem like there could be any connection, even if there were some increased rates, but there are not. So one more for you, Dr. Rudd, is there was some concern that there's a small component of the lipid components. It's called PEG, or polyethylene glycol, very small amounts in each of these two vaccines, but it is part of the lipid coating on each of these two. And there was some concerns that perhaps it could be triggering allergic reactions. Any thoughts on that?
Sure. So I guess it always exists the possibility that you could be allergic to anything. And I think that's where the warnings now of folks with severe allergies, just overall be cautious, as they would with any new food or medication. But this PEG, polyethylene glycol, is in many, many products, both pharmaceuticals, other vaccines, and in the foods that we eat. So to steer clear of the vaccine for that, particularly if you've never had a reaction to that or severe reaction, I think is really unfounded in this case. We're not really seeing, antibody development just from the very small amount that's in this vaccine that, as Dr. Hyman noted, that and many of the other particles, get broken down very quickly. Dr. Cohen, can I turn the table on you? I'm just looking at some of the chats here, and as a primary care practitioner yourself, there's a few questions in here coming in about regards to children, and are there any age limits, both young and old, who should not get the vaccine?
Yeah, so my understanding regarding the initial research of the vaccine is it was not yet researched in children. So as far as I know, we're 18 and over. On the upper limit, no, there is no limit. Now, I do understand, I don't know if Charles or Kelly, if you have, or Heidi, have any knowledge of this on what the ongoing research is for COVID vaccine in children, but right now we are not giving it to them, or won't be giving it to them, I should say.
I'm not aware of any of the trials. I haven't been on the NIH site to say for sure, but I fully do expect that there'll be, vaccine trials in children coming. We know children historically, as a mother of two who are under the age of 16, are not in the highest risk category. So I think the strategy for vaccine development and who it was initially tested on are those higher risk populations, particularly those greater than 65.
It's interesting as well, not only are they not in the highest risk category for developing severe disease, there was concern about, initially the Kawasaki-like syndrome that has not been all that common, thankfully. It may have been unrelated, but we're not sure about that. But also, the reality is if you look at school-based transmission, just look at that one, that one fact, school-based transmission, at least in our state of New York, has been fairly low. And I'm not sure why that is, whether it's transmissibility or, where kids are actually, following the rules between hand washing and wearing face protection. But either way, it is very difficult to study children and pregnant women. There's issues with consent. Kids don't react the same way to drugs and vaccines as adults do. It's not just, a 2-year-old. I'm a family doc. I take care of both kids and adults. And a 2-year-old is not just a little adult. They react very differently. They develop antibodies differently. So I think that was one of the initial reasons. The other is if we can get enough adults vaccinated, likely children will get some protection, that so-called herd immunity, although this is more Dr. Hyman's realm, but the reality is we don't know what the threshold is for developing herd immunity in our population. And what percentage of patients need to be vaccinated or immune due to native disease in order to prevent vaccine in the population. I don't know, Charles, any thoughts on that?
Well, we don't know specifically for this, for COVID, but in general, it's usually between 70, 80, or 90%. Between 70 and 90% of the population need to become immune in order to provide effective herd immunity. So we're quite a ways from that right now.
So Dr. Hyman, while we're on the topic of immunity, another question in the chat is there any thought about how long the immunity from the vaccine may be expected to last? And is this something that we may be looking at getting annual revaccination for, much like we do the influenza?
So really a great question, and one that remains to be answered. So we know from natural infection, there have been well-documented cases of people becoming infected a second time with COVID. We know that the levels of antibody that seem to be effective usually last for about 3 months after natural infection. So the duration and the durability of immunity from the vaccines and how long that will be, we don't know yet. And more to come on that. But that's a very important question.
And also related, there were folks who were asking if they have been tested as having antibodies already, either through donation or through study, or who have had COVID themselves, should they receive the vaccine?
So the answer to that would be yes. And indeed, in the study, certainly in the Pfizer study, and I believe also in the Moderna study, there were a small subset of people who were found to have antibodies, and they also received protection and derived benefit from getting the vaccination by comparison to those who received placebo, who'd had antibody and prior infections. So the answer is yes. The general recommendation coming out of the CDC is that if folks have had COVID, they should probably wait until after about 3 months before they were to be vaccinated. If indeed that's, they wanted to be vaccinated, they should wait about 3 months.
Sure.
Excellent. Thank you. We do have one more myth that I just want to make sure we get to, because it's something that's come up 3 or 4 times, even in my email. People emailing me these questions. And I don't know, how about Kelly for this one? Toss it back to you. Will an mRNA vaccine change my DNA?
No, so there's no way for mRNA, even though they sound similar, to be incorporated into the human DNA. It's really a protein that signals your body to manufacture something. So think of it like a letter. It goes to the factory in your cell and says, hey, produce this protein. And that's its job. It's not DNA. It has, coding. It's made up of proteins, and that's about their similarity. After it does its job and delivers its letter, we really do kill the messenger. So once it's done its job and told it to produce that protein, the body degrades it, as Dr. Hyman noted. So it doesn't get incorporated into the DNA of the cell. It's really just a messenger. And that's what the M means, messenger.
All right. Well, we're going to pass it off to Heidi Bond now. Then after she speaks about, delivery methods, timelines, things like that, we'll go ahead and take a bunch more questions. It looks like we have about 22 of them now in our Q&A section, so we'll get to as many as we can. So Heidi Bond is the director of the Otsego County, New York Health Department, and we'll pass it off to you, Heidi.
Thank you. Thanks for having me. And we've heard lots of great information on this excellent vaccine, both of these vaccines. And now that we know they've been delivered in our area, when are we going to see them? How is it going to roll out? So the Pfizer vaccine is going to be the first vaccine that we'll see. And that is shipped in a special ultra cold storage container. It also has to be held in an ultra cold freezer if the facility has that. But the way that the manufacturer is shipping it is in these shipping containers that can stay at the ultra cold temperature for up to 10 days by replenishing the dry ice. And they have constant temperature monitoring. So, so we know that when the vaccine is given to a facility, that it's kept temperature controlled and safe and effective, remains effective in storage. So that vaccine is due to come out any day now. We've seen it come to a couple of our hospitals in our region. And that vaccine will be given first to frontline healthcare workers. So those healthcare workers who are seeing patients and taking care of patients every day that have COVID-19. That's where we're going to see the vaccine first. Then as more vaccine becomes available, and we expect that facilities will get weekly shipments once it starts really rolling, we'll see it come out in a tiered approach. So with direct care providers being first, hospital workers, EMS will be included in that first round of people needing vaccination. It will then move to our high-risk individuals in the skilled nursing facilities, the residents and the employees. And in New York State has opted into the federal program to have pharmacies provide the vaccine to our long-term care facilities. So that will be done through an agreement with the pharmacies that the federal government holds, and they will provide the vaccination to the residents and the staff at our long-term care facilities. Once that's done, we'll then see it move to the next priority level, which would be other first responders, essential workers. In the state, it's up to the state on how this gets rolled out, and we're not really sure exactly what that's going to look like. So really a lot more to come on that, but expect lots of information coming out in the next few weeks on the availability of the vaccine and where you might fit into that category, the priority category. Next priority after that would be high-risk individuals in the public. And really, we don't have a timeline for that. It depends on a lot of factors, and we're not sure, if everything rolls out like we expect. We possibly could be vaccinating the public in late spring, early summer. Could be much earlier, could be much later. Really, we don't know. And we have been planning, public health departments have planned for many, many years on community pods, points of distribution. So when it does roll out to the general public, I expect you'll be able to get it in all the places that you now get your influenza vaccine. And also there will probably be clinics, community clinics set up, but lots more to come on that. The media will be your friend when that comes around. So you'll be needing to watch your local media for where you can get the vaccine when that's available.
Okay, thank you, Heidi, for that explanation. I think we're going to move on then, since we still have a bunch of questions to answer. Diana Parker, who works for Bassett Healthcare Network, she's in our Human Resources department and is one of our best cheerleaders for these sort of events, working with the public, is going to go ahead and read those questions, and she'll kind of try to push it to whoever seems like the most appropriate person to answer it. So Diana, thank you for your help here.
Well, thank you, Dr. Cohen. The first question is one that you and I have both addressed before, but it really is contact of contact of contact. So the question is someone who's being very cautious and mindful of staying safe and wondering about Bassett employees. So when they're interacting with Bassett employees, and they specifically mentioned the gym, and wondering how safe they are if they happen to be around a Bassett employee, as our employees are using the gym for showering is what it is. So it's a contact of a contact question.
Sure. Charles, maybe you take that one?
So that's a great question. And I would say I would refer back to Bassett did a study looking at the seroprevalence of COVID in Bassett employees earlier on, and found that it wasn't the same as the general population. It was about a half to a third lower. Mm-hmm. And so I think the message from that is all of the precautions taken by Bassett employees seem to be working in preventing infection. And so I would say that folks coming into contact with Bassett employees are at no greater risk for becoming infected. In fact, are probably at lesser risk from becoming infected from them than they are from the general population.
Myself as an employee, I mean, I feel safer coming to work than I do, say, going grocery shopping. I know the precautions that are being taken by staff here. I know, the great emphasis on wearing your personal protective equipment in the office, the hand washing, the screening that we go through every day to ensure that we're healthy. And our environmental services team using top-notch disinfectants and really keeping our environment very clean, not only for our patients, but our employees, and the additional precautions that we're taking in caring for our COVID positive patients, being in pharmacy and, up on the floors and things. I feel very safe. I've got the access to all of the best personal protective equipment and procedures through our infection control team to keep me safe, which in turn keeps me safe at home and out in the community and not spreading that. So that's my 2 cents on I feel safer here than I do, say, accessing just the general grocery store when I don't know what's happening.
And I work both in the clinics and in the hospital setting, although less so in the hospital setting. And again, same thing, in the clinics, we're using universal precautions, which has a different meaning now than it did a few years ago, but universal COVID precautions. So masks plus face shields. In the hospital, same thing. And if we're seeing someone who is a suspected COVID patient or a positive COVID patient, we're using N95 masks and gowns and everything. So our risks of a high level exposure, meaning a high risk exposure with any patient, is extremely low because we are constantly protecting ourselves, and we all wear masks and things like that, even with each other. So I think the risk of the secondary, or in this case, tertiary exposures is extremely low. And we talk about that at the public health, in the public health arena a lot.
Thank you all. Another excellent question here is about the safety. And this person said they are feeling better as they listen throughout the presentation, but wondering how is the vaccine tested or predicted what the side effects might be 5 to 10 years out?
Is that a Kelly question?
That's a tough question. I don't think we've had that experience to really be able to know, thinking through the process that we follow this with other vaccines, with other pharmaceuticals. I think this is potentially even a safer vaccine than we've seen of others. The concern about, mercury and things like that in vaccines, which are not contained in this one. We're not using eggs for the allergic reaction to generate these. So I think it's early because we just don't have that experience, but just from the composition and from how it's made, I don't think there's any really signal there that there would be long-term negative impact.
And I think some of the vaccines we've seen in the past that could have long-term negative impacts are those that were live vaccines. There are some syndrome can occur, later on in live vaccines, but this is not one. Thinking back to, hepatitis B and flu and others, any side effects tend to be fairly quick, not long-term. I don't know about you, Charles, but I can't even think of a single one, or Kelly, that we've known long-term side effects from that didn't develop early on anyway.
I think that's a good point, Scott. I would say that I can't think of side effects that come up from vaccines that aren't manifest soon after, but only appear, years later. I can't think of any offhand. So I think your point is the right one. I think this is very, very unlikely.
Right.
Mhm.
Normally, we only see that more so, with a small handful of medications that are taken repeatedly over long periods of time. So that, would be completely different than, a vaccine that you have once, which helps confer immunity, but the actual medication, if you will, itself is gone very rapidly.
I think
Thank you.
another good point to make is that the vaccines will continue to be studied as they're given. We have already established a VAERS reporting system, so vaccine adverse events reporting system. So should someone have an adverse effect after a vaccine, that gets reported, and it gets reported all over the country, so that anything that might show up will show up quickly and can be looked at and studied.
Great point, Heidi.
Thank you. Another great question here is, I'm hearing about 2 different vaccines. How do I choose which one?
I think that's probably best for Heidi because the
Yes.
answer is pretty obvious.
So you probably don't have a choice. The Pfizer vaccine is probably going to be the one that's going to be available to the healthcare workers because of the difficult storage issues surrounding that vaccine. So I think that's not going to be one that's going to be available to the public as a choice, or even to some essential workers. So.
Between the vaccines, are both, very highly effective and are considered equally effective from that standpoint. Here through the Bassett Healthcare Network, we actually have the Moderna vaccine, and our choice really looked at the safety. They're both very safe, very similar safety profiles. They're both very highly effective, but as Heidi noted, it really comes down to the storage. So for us to be able to get vaccine to our patients and all the communities, a lot of places are probably going to opt for the Moderna vaccine, which has much more favorable storage and ability to be transported out to our regions.
I would just add, I think the way to make the choice is whichever one you can get first, get that one.
Great strategy, Dr. Hyman.
Great answer. A really good question here from a health educator asking, do we know if the lipids are animal or plant-based? She's trying to stay way ahead so she can be proactive as she teaches others.
I saw that one on there, and I was trying to Google while other folks were talking, and I don't have a great answer for that. Usually many of these are synthetic, so not animal derived, but I'll have to let somebody else take that question and come back to it.
Is that whether it's okay for vegetarians to get this or vegans to get this vaccine? Is that sort of where we're going?
I really don't know. I read exactly what the question stated. So they were just wondering, and that could be where it stemmed from.
It's an interesting question. I look forward to the answer, Kelly. Let us know.
So there are several questions on here talking about those people who are immunosuppressed or immunocompromised. And the concern is 2 points. When will they be able to get this vaccine? And is it still safe for them when they have these other underlying issues?
Yeah, I don't think we're 100% sure what the timeline is going to be for each of the populations or subpopulations of people in the United States who are going to get it. We're just not there yet with the rollout. And I think we're telling people to just, pay attention to your news media. Your PCPs aren't going to know anything yet, nor is your home hospital organization. But we will know at some point in the next few months. In terms of whether or not it's safe or not, there's actually 2 questions. Number one is it safe for that immunocompromised to get it? But then the second question is, will it be effective? There are certain medications we use that make the immune system less responsive to vaccines. And there are certain states that make us less responsive and also riskier. That being said, and I defer to Dr. Hyman and Dr. Rudd, but I can't think of any states that would make these vaccines riskier because they're not live vaccines. They're not things that we give and we have to make sure the body fights off. That's just not the way these work. Any thoughts, Charles or Kelly?
Yeah, I think you're absolutely right, Scott. And I just hearken back to a point that I made earlier on, which is there are many different branches of the immune system. So when we talk about immunodeficiency, we really are talking about what's potentially a very broad array of problems. And so there can be many different parts of the immune system that may not be functioning quite as they should. And so I think this is, if somebody's concerned about this, they should probably discuss this with their provider or their physician who's overseeing their treatments for their immune deficiency and come to a decision with them. I think that would probably be the best approach.
Thank you. So here's a really timely question, and this is about the regional vaccination hubs and the Mohawk Valley region, which is Cooperstown. The question is, how is the Mohawk Valley Medical Center and health system interfacing with Bassett?
I can certainly speak to that, or either of my colleagues. This is fairly straightforward. There's not a huge number of doses that are attributed to us in the Mohawk Valley Health System or several other systems, because remember, our geography is 5,600 square miles. So to our south, we have a few doses that UHS holds. To our west, we have a few that actually even Arnott has, Arnott Ogden. So what's happening is those organizations are working with our incident command teams, and we're defining who would be the appropriate candidates to travel. Remember, we can't ship those vaccines from those sites to us, but who would be the best candidates to travel to those sites twice to get their first and second doses. And obviously, we're doing it based on the geography of where people live and also where they work.
In terms of interfacing, so I'm on the team that's been helping coordinate those efforts between the organizations, and it's been a great community effort. There's been a lot of communication and planning calls between all of the organizations, as Dr. Cohen mentioned. So it's been a very great collaborative effort for our region.
Great follow-up question to that, and I can send it to both of you again. Once this vaccine is available to the general public, are there concerns about the supply chain? And since there's a second vaccination required in a relatively short amount of time, are you concerned about a disruption and people would have to start over again?
There's always concerns about supply chains nowadays, as Kelly will tell you, from EPI to you name it, drugs that are on short supply that we have trouble getting and have to substitute, sometimes in good ways, sometimes in not so good ways. That being said, the way this is being rolled out is in paired doses, is what I understood, such that if you got your first dose, the second dose is waiting for you. We're not starting it into the next group of people until we have enough doses for that first group. I think that was kind of the basis of the question, right?
Yes,
Yeah.
Thank you.
Yeah, and they're doing that also on the skilled nursing side, so that that they know that they'll have 2 doses. Another part of that question was, would you have to start the process over again? And you would not. So if you got one vaccine and you had to wait more than 3 or 4 weeks, you would not have to restart the process, but you would then get your second dose as soon as possible.
So a question that has come up again is Moderna 1 time and Pfizer 2 vaccines, or are they both 2? So there's a little confusion between the difference.
Sure, all of the vaccines right now are a 2-dose series. It'll be important to note which vaccine you get the first time, because as Dr. Hyman noted, one is 2 weeks between and the other, one is 3 weeks and the other is 4 weeks. So you'll need to know which vaccine you got the first time and have that vaccine the second time is what is recommended. But all of them are a 2-dose series. And when you get your first one, you should be making your appointment for the second.
One question about risk, and this is, if you are a high-risk patient, do you have a greater chance of getting serious side effects from either vaccine?
That was not shown in the studies. Indeed, people that were older, over the age of 55, had less side effects than folks that were younger. It's not exactly clear why that is, but it would seem that both trials from both vaccines indicated that. So the short answer to that question is no, not that we know of.
And speaking to the studies too, there was a question of how many people, when you mentioned 30 to 40,000 that were involved in the testing, how many of those people actually got the vaccine and not the placebo?
So if you combine 30 to 40,000 each per vaccine. So the Pfizer studies included, the major studies included, I forget the exact number, 38,000, something like that. Half of those got the vaccine, and the Moderna, a similar number, and half of those got the vaccine.
Excellent. Thank you very much. I'm trying to go through any other themes here. I think we have covered most of the themes that I am seeing here. And so, we did get a response. The question on the lipids was about vegan concerns, exactly as you had mentioned. We really seem to see the question. Oh, here's one. Anticipated cost. Great question.
I don't know, Heidi, your understanding, but my understanding was the cost that is free to the public.
Correct. Yep.
The only caveat to that is that organizations may charge to administer the vaccine to cover the supplies and the time to do so. So while the vaccine may not have a charge, there may be some costs associated with the labor and supplies and such to do that, but the cost should be much smaller, you would anticipate, than other vaccines.
Mm-hmm.
So I want to be respectful of our time. I have one last question on here, and I will let everyone know this has been recorded. We will be posting at least a summary, if not the entire webinar. And the last question that I see here is, are teachers and college faculty included as essential workers?
Essential workers have had a varied set of definitions in the U.S., and they're working on what essential, so there's essential workers, which is about 70 million Americans, believe it or not. And then there's essential frontline workers, which I do believe teachers do fit into. But the CDC and the states make the final determination on the rollout within our individual states, but the feds are producing guidelines for that. So that remains to be seen at this point.
And if we have time for just one additional comment, I'm just looking on here, and I think this is a great point that we shouldn't miss, is after receiving the vaccine, would you forego current safety protocols? And I think the answer is a resounding no. So the vaccine is just one tool in the toolkit to help fight this COVID vaccine. We still need folks to be smart about social distancing, wearing masks, hand washing, staying home if you're sick, limiting contacts, and doing all of those other right things that we've been encouraging folks to do. But the vaccine doesn't negate any or all of that.
I'd just like to add to that, Kelly. I want to thank you for bringing that up. That's a very, very important point, is that the vaccine trials have shown that it prevents disease, not infection. And so people may still, we don't know, but they may still be infected and still be able to pass it on to others, even though they've been vaccinated, but they're not getting disease. So that's a very, very important point, and I'm glad you brought that up. Thank you.
Okay. Well, I think that kind of puts us at the end of our session here. We really appreciate everyone logging on and all of my colleagues, Kelly, Charles, and Heidi, for being on today. Please, we really feel as a group that getting vaccinated is extremely important, as well as Kelly said, using our other strategic methods, social distancing, mask wearing, hand washing, and others to try to stay safe. It's going to take really a multitude of methodologies to get rid of this pandemic and get us back to normal. So please, even small gatherings now are really causing a lot of disease, including in my county, and I believe in Otsego and others as well. So even small gatherings now probably, are not the best idea. Please also stay tuned to news media regarding the rollout of vaccines, meaning when your group is going to be getting it, since your healthcare providers, meaning PCPs and others, are not going to be any more aware of it than you are until we actually get the vaccines. So with that, we certainly thank you for attending today. Hopefully we'll be doing more of these webinars in the future, and have great holidays, everybody.
Thanks, Scott. Thanks for putting this together.
Mm-hmm.
And thanks everyone for joining.
Thank you.
Bye now.